Welcome everyone to the Understanding School-Based Mental Health and Medicaid webinar series. This 5-part series is designed to build a shared foundation of understanding how Medicaid supports mental health services in both school-based and community-based settings across the state of Illinois. The vision of this series is to support the provision of mental health services to students within school settings to reach all youth, and especially those that may be most vulnerable that cannot access services otherwise. My name is Matt Buckman. I'm a licensed clinical psychologist, duly credentialed as a school psychologist, and also the executive director of the Stress and Trauma Treatment Center. I will be guiding you through today's content and this 5-part series. This webinar was developed with support from the U.S. Department of Education's School-Based Mental Health Services Grant awarded to West 40 Intermediate Service Center No. 2 in partnership with the Stress and Trauma Treatment Center. This material is provided for educational purposes as a broad overview. It does not replace the official guidance from HHS, CMS, or the Illinois Department of Healthcare and Family Services. Regulations and compliance requirements can change, and participants should always consult authoritative sources. This is a 5-part series. This series progresses from foundational Medicaid concepts to increasingly more specific applications. Starting with a foundational understanding of Medicaid allows us to dive deeper into the school-based reimbursement system, community mental health services system and reimbursement for this, and specialized care coordination service organization and pathways programs. The final part of this series will be a discussion of ideas for action, which will build on the previous content and identify concrete steps or strategies to leverage funding to increase access to mental health services for students. Part 1, Understanding Medicaid and the Foundation of Medicaid Reimbursement for School-Based and Community-Based Services. The agenda for this is to go over the history of Medicaid legislation over the last several decades that has led to where we are now. To talk about school-based mental health services and how school Medicaid reimbursement and the funding models that are there are able to support, expand, or sustain school-based mental health services. Starting with the Social Security Act, which was developed during the Great Depression, President Roosevelt led this effort in 1935, and then it was again expanded and enhanced multiple times throughout that time period. One of the main goals of this legislation was to provide economic security for the masses as well as those vulnerable population, such as during retirement or after family members had passed away, or a disability or disabling condition were developed, to try to reduce poverty and provide stability for those individuals that needed it. Take that same legislation, and in 1965, that legislation was built on, and the development of Medicare and Medicaid occurred. Medicaid specifically is for individuals that are of low income or below the federal poverty level, or medically vulnerable individuals. The goal of this is to make sure that vulnerable populations do get access to services and that long-term supports and services are covered, and to reduce the inequities of coverage for individuals that have a disability or individuals that could not afford premiums, or low-income individuals that do not have access to healthcare coverage. In 1997, CHIP legislation was passed. That's Children's Health Insurance Program. CHIP legislation then allowed the expansion of eligibility for children and what kind of eligibility could be out there that the federal government would provide or contribute funding to for states to be able to adopt. It is still a state-administered program, and in that, the states get to determine what is the eligibility criteria within the parameters of the federal government. The state gets to determine whether or not they adopt this full population or a subset of that population. the state still has a lot of control through CHIP. That CHIP legislation, the goal of that was to reduce the number of uninsured children in the United States. And that provided both the change in eligibility, but also an enhanced match rate or FMAP rate, which is the federal medical assistance percentage, the percentage that the federal government would match every dollar that was spent for children who meet the criteria. More recently, the Affordable Care Act made an impact within Medicaid and Medicaid services that were provided. In addition to influencing what would be the reimbursable services and several other aspects of this, it also changed who was eligible for Medicaid. There were several populations that were considered more vulnerable populations that were uninsured. The Affordable Care Act then started to provide some support, subsidies, FMAP or match to be able to help states enhance the services and provide coverage. But it was still the state's choice. For us, we found with children's services, with services or coverage for pregnant women or unborn children or caretakers of children, that we had already had all kids and family care, previously kid care for all kids. We had already had a lot of the coverage that was necessary for those populations. But one of the unique populations was our 19 to 64-year-olds that were not caregivers or didn't have children and were not considered disabled. Those individuals were the true expanded population, as well as some others and some other resources and coverage of services that the Affordable Care Act did make an impact in our state. When we're looking at the Medicaid expanded population for adults, prior to the Affordable Care Act, these individuals were not covered by Medicaid and not eligible for coverage for Medicaid. Post the Affordable Care Act, we're seeing hundreds of thousands of individuals getting coverage, close to even 1 million individuals getting coverage, with a peak of 941,000 in March 2023 through the Affordable Care Act. When we look at children coverage has been pretty stable or constant, with some increases through some of the legislative changes that have occurred or additional efforts for outreach and helping people get covered. But for children, we saw early on in February of 2020, about 1.3, 1.4 million children covered through Medicaid, with an increase to almost 1.6 million individuals covered or children covered through Medicaid. Seeing that increase with a slight decrease over time, but we're looking at some expansion, but a lot of the expansion our state had already done, and our state had been doing since 1998, or the initiation of the 1997 Children's Health Insurance Program that had occurred. In addition to who's eligible, also it had an impact, or this legislation has impacts on how much money or funding comes from the federal government for relief or support for our state to be able to provide Medicaid coverage for individuals. When we look at the standard population of who was eligible under the federal poverty with the amounts of household income under the federal poverty level that are children or caregivers at 40 to 50% of the federal poverty level. When we're looking at things like that, what we're able to see is it's a pretty standard match rate. Children's match rate has increased or did increase in the initial phases of the Affordable Care Act. And the adult population that was uninsured, that had a significant increase from 0% match to 90% match through the Affordable Care Act, and continues to have 90% match at this particular point, but is debated and an at-risk population for future Medicaid coverage. Whether it's one side or the other, and which direction's the right direction to go, is beyond this conversation or this presentation. But that is an at-risk population. These enhanced rates or enhanced match that happens from the federal government matching what's spent at the state government level for Medicaid services. The earliest one that I know of is through CHIP, or Children's Health Insurance Program. And that enhanced rate started back in 1997 to try to support states to create an expansion so that children, not just children under the federal poverty level or from households under the federal poverty level, but instead an expanded group and creating more children to be eligible for Medicaid coverage. That in 1998, the state of Illinois did enact that and has been providing more children's or expanded children's Medicaid coverage ever since. We see some changes over time with enhancements. These enhancements come and they go, but the overall enhancement that was enacted in 1997, that continues to be here in our state and continues to support children being covered by Medicaid and eligible for Medicaid coverage. Federal medical assistance percentage, or match, is something that is provided to share the burden, share the cost to administer Medicaid and cover Medicaid eligible populations between the federal government and the state government. The state government always administers Medicaid. The federal government provides guidance around that and determines, based on reporting that comes from the State Department to the federal government, determines how much match, or FMAP, ends up occurring based on overall formulas, but also the types of services that can be covered. Within our traditional FMAP, our state, based on income, is about 51%. So for every dollar that's spent in clinics and hospitals and schools on Medicaid eligible services for Medicaid eligible individuals or benefactors, that dollar, the State Department will receive 51 cents or 51% from the federal government to be able to cover that cost or provide a match to the money that is being spent. Over time, we're seeing the FMAP, or match rate, for the state of Illinois pretty much being stagnant or staying the same at around 51%. And some states have higher rates. 50% is statutorily the lowest amount that it can go. Some states have higher because their states are considered more low income as a whole, whereas Illinois is not considered that as a whole. We can see this is a pretty stable rate, but we do see increases at different periods of time. One in 2008 from the American Recovery and Reinvestment Act that was happening following a recession, and again in 2020-ish for the Affordable Care Act, and then for it to return to about the same rate after 2024 for our traditional Medicaid eligible population. During the Affordable Care Act, prior to the Affordable Care Act, we were seeing that traditional rate, 51%-ish, or 51 cents matched for every dollar spent by HFS, our Healthcare and Family Services. That is our lead Medicaid agency that's issued out through clinics, schools, hospitals, etc. CHIP, or Children's Health Insurance Program, that I was discussing before, all kids in the state of Illinois prior to the Affordable Care Act, 65% or 65 cents was matched for every dollar spent on that population, or that expanded population. And then for the Affordable Care Act, CHIP then increased to about 88% or 88 cents for every dollar spent was matched by the federal government. That enhanced FMAP or match. That kind of stayed the same until the Affordable Care Act, and then that was enhanced for a number of years there. And then again, it had a small enhancement through the Family First Coronavirus Response Act in 2020. As well as the overall FMAP had, or match had a small enhancement during COVID that did occur. But overall, then it returns back to our pre-COVID numbers, which are still enhanced. Match was 65 cents for every dollar spent is matched to or provided to the federal or to the state government from the federal government. With the Affordable Care Act expanded population of adults, we're seeing 90% of that amount being matched. So for every dollar spent in the state by HFS to one of our local organizations or entities that are providing services to individuals, for every dollar spent, 90 cents is matched by the federal government. In our state, as I said, we've had a long history of providing coverage, Medicaid coverage to children, and not just children below the federal poverty level, but the expanded population ever since CHIP was created. So in 1998, Kid Care was created that followed CHIP and used the enhanced match rate that was available through CHIP. And then in 2005, All Kids was created. 2006, it was expanded to cover all uninsured children, and then used more of the CHIP enhanced reimbursement rates, or not reimbursement, I'm sorry, match rates that were there. And then the Affordable Care Act, we saw an increase. And now 2024 and beyond, we're back to what was it like prior to the Affordable Care Act. And it's still an enhanced match rate that is provided. Through All Kids and Family Care, eligibility does remain the same because we had already expanded significantly within our state and had been doing so for over 2 decades. We're still seeing children that are up to 318% of the federal poverty level, that those children are eligible for Medicaid or CHIP or All Kids. Pregnant women up to 213% of the federal poverty level would be eligible, and caregivers up to 40 to 50% of the federal poverty level are eligible for Medicaid coverage. This population is pre-Affordable Care Act and would be post-Affordable Care Act, even if, or most likely be post-Affordable Care Act, even if some of that legislation did change. And I'm not saying right or wrong to do so. I'm saying that even if some of the worries and fears do end up occurring, that could end up changing things. However, given the match system that we do have within the way Medicaid does work, that does pass on more of a financial burden to our state, which then there needs to be more state funding or state budget to be able to provide that type of support. Medicaid legislation not only adjusts who is eligible or determines who's eligible for services, as well as how services are matched or money is contributed to the state to be able to administer Medicaid to the state population, but also legislation such as the Affordable Care Act will govern what types of services are permissible to be able to be provided through Medicaid reimbursable activities. Another one of those pieces of legislation is specifically EPSDT, our early periodic screening, diagnostic, and treatment. This first legislation came out in 1967 with multiple revisions over time. One of the key goals of this legislation was to ensure that low-income children receive preventative and early intervention health care before larger medical or mental health problems become more severe or costly. We find this is a common model or value even today, whereas we want to work more upstream and we want to work more in early identification of mental health challenges so that we're able to address them with lower cost, lower resources, more efficiently, and before more significant habits and or chronic or crisis type of needs start to arise. In 1997, there was a clarification from CMS, Center for Medicare Medicaid Services, of the free care rule restriction, which was then limiting the services, and for many decades, limiting the services only to students with IEPs or IFSPs, so individualized education plans or individual family service plans for younger children. This limited what was reimbursable by Medicaid within states across the nation. In 2014, a letter was written by CMS that clarified that they were withdrawing this guidance on the free care policy as expressed in their guidance and their ruling and regulations. At that point, they indicated that the free care policy, as it was applied, actually prevented the use of Medicaid funds to pay for covered services furnished to Medicaid eligible beneficiaries. What was part of this was if we were providing free services to someone else that wasn't a Medicaid client, we couldn't provide services to an individual with Medicaid client that had Medicaid and get reimbursement for that. And so since services in general education oftentimes are provided to everyone, that was regular. That was where the free care rule came into play. But ultimately, they said the goal of this guidance is to facilitate and improve access to quality healthcare services and improve the health of communities. And so seeing as that was a hindrance to the provision of services to youth and students with Medicaid specifically, that has now been lifted, which allows us to look at our state plan. And the state of Illinois did so and decided to revise our state plan through a state plan amendment or SPA back in July of 2021. Now, that plan was under review and maybe back and forth with revision a few times before it was finally approved. But after that approval, it went back to July 2021 as the effective date for this. And we found very promising opportunities, such as changing the way the methodology is, who's eligible for services, are eligible to provide those services, and how we're able to provide services to the entire student population, not just those who may have an IEP or IFSP, because there are many, many students that are in our communities and in our schools that need just as much, and which is why we ever implemented Medicaid services in schools and mental health services in schools, because we know the need is great and we're trying to address those needs.
Medicaid school-based services, also known as Medicaid SBS, are any physical and/or mental and behavioral health services provided to Medicaid-enrolled children in school settings or by school-based providers that are reimbursable by Medicaid. These services often include early and periodic screening, diagnostic, and treatment (EPSDT) services. EPSDT services are a type of Medicaid benefit that provides comprehensive and preventive healthcare services for Medicaid-enrolled children under the age of 21. EPSDT services are key to ensuring that children and adolescents receive appropriate preventive, dental, mental health, specialty, and rehabilitative services. Schools across the United States currently support access and delivery to physical and/or mental and behavioral health services in a variety of ways. Some examples include school nursing, school counseling and mental health services, occupational and physical therapy, speech-language pathology, sometimes called speech therapy, school-based health centers, which offer a full range of health services, dental services, vision and hearing screenings, audiological services, substance use prevention, screening, and treatment services, and clinics offering vaccinations, such as the flu vaccination. Schools can provide these services directly using their own employed providers and in partnership with other organizations, such as private healthcare providers, federally qualified community health centers, school-based health centers, public health systems, and hospitals. Why schools? Approximately 56 million children are enrolled in K-12 schools in the United States. Students spend an average of 6 hours a day in school, making it an incredible opportunity to deliver physical and/or mental and behavioral health services to those in need. This helps keep children in schools, especially those that may have limited access to health care. This also enables students with disabilities who need services in order to learn at school to receive them. School settings offer a way to improve health equity by reaching students with low household incomes. Delivering these health services to students in schools also reduces absenteeism, especially chronic absenteeism, reduces or eliminates the time and cost associated with transportation and scheduling health visits, reduces future health services needs by providing timely preventive care, and reduces stigma related to receiving services and support. Services at schools complement and do not replace services that students receive through their healthcare homes, usually pediatricians' offices or other community providers. Simply put, children who access physical and/or mental and behavioral health services in schools are less likely to be absent and more likely to graduate, be healthy, and earn higher wages as adults. Why is Medicaid important in providing school-based services? Medicaid plays a critical role in providing health services to children in schools. Approximately half of all children in the United States, or 38 million, are enrolled in Medicaid or the Children's Health Insurance Program, CHIP. Approximately 3 million of these children currently receive health services funded by Medicaid at school, and many more children may benefit from these services. With Medicaid coverage, schools can receive reimbursement for health services they already provide to students. Schools can seek reimbursement for delivering covered Medicaid and CHIP services and associated administrative and outreach activities. Medicaid SBS can be combined with other approaches to delivering physical and/or mental and behavioral health services in schools to ensure that the needs of all children are being met. Medicaid services provided to Medicaid-enrolled students in schools helps to reach more children, which may, in turn, reduce absenteeism, bring in additional providers to meet student needs, redirect dollars that would have gone to pay for services for Medicaid-enrolled students back to schools, and lessen the need to use general or special education dollars on health services and increase what is available for teachers. Medicaid SBS particularly matters to schools that serve children with disabilities, which is all schools. Under the Individuals with Disabilities in Education Act, IDEA, children with disabilities are guaranteed access to a free and appropriate public education, FAPE, including all services outlined in a child's Individualized Education Program, IEP. Many students with disabilities require physical and/or mental and behavioral health services to make it possible for them to learn. Medicaid reimbursement for those services reduces special education costs and supports limited education budgets overall. While Congress appropriates funds to cover IDEA-related needs, federal IDEA funding only covers approximately 16% of the cost to educate children with disabilities, leaving the remaining costs, approximately $17 billion, to states and local governments. Medicaid funding can help fill the gap for some health services. Annual Medicaid reimbursement to physical and/or mental and behavioral health services reduces the $17 billion IDEA burden on states by approximately $4 billion. Medicaid reimburses schools for outreach and enrollment activities, as well as coordinating other services, like food assistance, that a student enrolled in Medicaid or CHIP might need. In other words, leveraging Medicaid funding helps schools help children succeed.
Illinois school-based health services were first launched in 1992. HFS is the lead Medicaid agency. They're number one, their lead vendor for the statewide administration of school Medicaid reimbursement services is PCG, Public Consulting Group. And then each district will likely have their own vendor for interim claims as well. And there's only a handful of those that are facilitate most of the interim claim and other process that are oftentimes a really good resource for technical assistance and guidance on how to enhance Medicaid reimbursement activities within your district. Now, in 2021 was when the state plan amendment was administered, but it was in perhaps revision and review for several years, but the state plan amendment still goes back to July 1st, 2021. And so it goes back to the original submission date. And so there were some changes that did end up happening within the state, but vastly the majority of districts have not or had not implemented significant changes for the state plan amendment and for free care rule, but now definitely has the opportunity. And we are hoping to see our entire state rise together to increase the amount of federal medical assistance percentage or match that comes to districts for the Medicaid reimbursable services, especially through free care, that was not possible before. And so then, and in FY24, school-based health services addressed the needs of 244,000 Medicaid enrolled students. Now, Medicaid reimbursable services, there's lots of different service types and provider types, from nursing, speech language, social workers, psychologists. There are lots of different service types that are out there. It both provides reimbursement for direct service costs and we call it the provider pool, and administrative costs. And so the additional costs that are involved in the number one activity that I would encourage is outreach, trying to make sure that Medicaid eligible students are obtaining or have Medicaid, and are receiving the services that might be needed through like an EPSDT framework. And just as a reminder, services are no longer require an IEP or IFSP to be Medicaid reimbursable. Now, students that are eligible for IEPs still, go down that route, but that is not the only eligible Medicaid reimbursable eligible set of services. They don't have to originate from the IEP, and they don't have to be students with special education diagnoses. They can be students that have other types of diagnoses specific to school-based mental health services. Anything in the DSM or even partial criteria met. Some, EPSDT would also perhaps say, even if there were some at risk or provisional preventative diagnoses that might be there, as long as medical necessity, there's something that determines medical necessity exists, which could even be a screening positive or a certain assessment or screener tool, but something that determines there is a necessity for the services that are being provided. And specific to mental health services, now we're seeing licensed clinical psychologists and licensed marriage and family therapists, licensed clinical professional counselors, and even registered behavior technicians that could be providing behavioral health or mental health services and supports to our students. The other adjustment is from a rate settlement to a cost settlement reimbursement methodology. And the main point I'll make here is that the cost settlement model will end up kind of flushing out all of our interim reimbursement that has happened throughout the year. So if a provider submits a reimbursement activity with their vendor, that activity then can get reimbursement by the state of Illinois throughout the year. And at the end of the year, we're going to look at how do we settle this out. So if I maybe received $100,000 in interim payments, but my cost settlement would suggest that our district would be eligible for $150,000. Then at the end of the year, I would get a $50,000 increase after my cost settlement. And that may include a lot of the administrative activities that maybe they don't go into interim billing oftentimes. Also, the random moment time study change is that we are reliant more in the on the random moment time study system. So it's an especially important system that's there. So even though for the first couple years, really we didn't have an approved state plan amendment, it was in review and or revision. Even in year one and year two, we are seeing significant amounts of money or increases that are coming to the state of Illinois. And this is going directly to districts. And so the FMAP, the match, is what districts are eligible for. So that goes directly to districts themselves. And then districts cover the other portion of the cost, which could be through general funds or property taxes, or perhaps other state grants or initiatives that may be covering the expenses outside of what can be reimbursed otherwise. When we're looking at FY23, this will show you kind of the total for that was for direct services, $232 million in funding for that year, and about 83 additional million in administrative services or costs. Again, well, the number one is going to be outreach type of activities, trying to helping eligible students obtain Medicaid, enroll in Medicaid, and get the services that they need. But another point that I'll make is in that if you look at that pie chart, when you look at psychological counseling, social work, school-based mental health services is the largest percentage of service activities that contribute to the Medicaid reimbursement that goes to districts. Oftentimes, special education cooperatives, if that's a model that you're used to in your district, oftentimes they're the entity that are receiving a lot of this reimbursement. And we may not always be submitting or involved in a reimbursement system for district staff that are not part of the special education cooperative. Whereas now a social worker, a counselor, a psychologist that is employed by the district, even when there's a special education cooperative in your region, that those individuals can now start to use the free care rule, and reimbursement can happen for those individuals in addition to what is happening for special education cooperatives or the students that are being served through the IEP system. I mentioned this already about medical services being reimbursable, and those services still have to fall under the Medicaid or medical state plan and or EPSDT. And so there are some variations there, but there's guidance, there's regulation on services that are going to be reimbursable and services that are not going to be reimbursable. And so I'll talk a little more about this in the next part of this series. The cost settlement formula, or here's a generic formula, it has more complexity to it. But if you look at the total cost, both indirect cost and direct cost, And if you have a negotiated indirect cost rate, then that can go into this. If you don't, you may be doing the de minimis. That multiplies by the medical percentage, the percentage of the time through the random moment time study that individuals are providing reimbursable services or approved services. And so that could be working with a student with Medicaid, but if I'm doing an unapproved service or I'm doing a service that doesn't require my licensure for mental health services, as an example, then that would not count here. But if I'm doing a service that does require my license, credential, training, and a service that is on a plan of care that I've determined medical necessity for, and the student has Medicaid, that will show up here. And so multiply by that from our random moment time study and by the medical ratio or Medicaid ratio, and that's the ratio of the total number of students that have Medicaid divided by the total new students overall, and that will give us the Medicaid ratio provided and then multiplied by the federal medical assistance percentage, or that's the match rate, the FMAP rate, just going to be our standard FMAP rate, not the enhanced rate. That is around 51%. And during COVID, that was a little bit higher at around 56, 57%. That was a temporary enhancement across the entire nation. But around 51% would give me my total medical allowable cost, or the total amount that I could get reimbursed for. So if it's $128,000, if I received interim payments of $100,000 throughout the year, then that would be at the end of the year, my cost settlement would have me getting reimbursed for $28,747.40. Now, on the flip side, unlikely but possible, if I had received interim payments of $150,000 and my total cost was $128,747 based on how I use my cost pools and what information I put in there and how my district did the random moment time study, which are all, those are kind of some of the controllable variables. If I if that was the case, then basically in the next year, I would not get the first whatever that is, $32,000. I would owe that for the next year because I received more interim payments than I actually settled on at the end of the year. But again, that's less likely to be happening, but is possible in that system. So, why does all of this matter? In that um, we know that mental health needs and the struggles of youth and the stress that youth are under, and the effects that has on both physical and emotional and behavioral health, that this continues to grow and we need more and more supports and more professional supports, and students, especially students in underserved communities and from more vulnerable families, they're not necessarily going to be able to get access to the mental health services that they need, which then ends up creating bigger problems, and it turns into more of a crisis type of cycle, or a danger to themselves or others. And we're finding these unmet mental health needs are going to grow into bigger issues. And so, as we're doing that, a multi tiered system of support, or MTSS system, for the mental health needs of students, looking at how do we address, we provide universal supports that will address the needs of 80% of those students. But then, when that's not enough, we then can start overlaying some tier two additional mental health supports and services and counseling and case management and care coordination. And then tier three, more individualized or tertiary interventions on top of tier two and tier one supports for those students. Those types of things are less, there's less capacity, perhaps, less opening, more wait list, or less access to, or more demand even, that creates less access to those services in the community, oftentimes leaving the school with the need to address this either through our own staff or through partnerships, which we'll talk about both models throughout this series, so that you're able to use Medicaid dollars to be able to provide the services to students that are needed, and providing some of these much needed mental health professionals in your schools. We're seeing social workers, counselors, psychologists across the state. We're seeing the ratios are improving, meaning there are more providers than there ever have been in each one of those. But we know it's still not enough. We're still about double the amount that, or the half the amount of providers than what we need based on best practice ratios. And we see this in our students and in our families, and the needs keep rising while we are stretched thin to be able to provide those services. So as we expand, we're going to need dollars to be able to expand and support and sustain these positions. We are seeing, again, the numbers are growing in all the fields there, from school social workers, school counselors, school psychologists, with the largest number in school social workers um, providing services across the state of Illinois. But we need to keep growing and keep expanding, and we need dollars that are sustainable to be able to, that are not soft grant dollars. Those are important too, but we need sustainable long-term dollars to be able to allow for this expansion and to support the mental health services that our students need across the state of Illinois. There's a ton of great resources. Again, down in the description, you will see links to all of these resources. Please visit those. There's deeper dives into a lot of content that we've only scratched the surface. I hope that you have enjoyed part one of this series. Please stay tuned and jump into part two or return back for part two. We're going to do a deeper dive into school-based mental health services and the Medicaid reimbursement system within districts, and what does that take. Thank you very much.